very good morning and hello to everyone. I am Dr. Pratik Manik. I am working as an assistant professor in Department of Cardiovascular and Thoracic Surgery at the UNMICRC Institute of Cardiology and Research Center. In the present video, we would look into the topic of post myocardial infarction VSR and discuss the features of the VSR as well as the clinical features, the management, as well as the outcome and the long-term survival. Coming to the history of VSR, in 1845, Latham first described the post-infarct VSR in a case of an autopsy. Thereafter, Brune in 1923, he first diagnosed an antemortem case of VSR. And Sager in 1934, he established an association of post-infarct VSR with coronary artery disease. It was Cooley in 1957 who did the first repair of a post-infarct VSR, and in 1963, Kirkland reported the first long-term survival after the surgical repair. Coming to the incidence, 1 to 2% of the patients who develop an acute myocardial infarction tend to develop a VSR, and 5% of the deaths following and after myocardial infarctions are contributed by ventricular septal rupture. Mean age of incidence is 62.5 years, with male to female ratio is around 3:2. Majority of these patients have the first episode of myocardial infarction. They usually do not have any history of myocardial infarction or chronic ischemia. It usually presents with a bimodal peak. The first peak appears within the first 24 hours after the myocardial infarction. Thereafter, a second peak appears, that is between 3 to 5 days following an episode of myocardial infarction. Any VSR that is presenting after 4 weeks of developing a myocardial infarction is usually termed as a chronic VSR. Coming to the pathogenesis, any myocardial infarction that causes transmural infarct, which usually involves a greater wall of the left ventricle, and the infarction to the rupture time is usually between 2 to 4 days. It is usually a case of acute complete coronary occlusion, and the patients usually have a less extensive coronary artery disease and have very less developed collaterals, which tend to lead to an acute episode of MI and then after a septal rupture. Coming to the anatomy, 60% of these septal ruptures, they happen in the anterior septum. It usually occurs due to the acute occlusion of the LAD, and it happens usually in the distal half of the anterior septum. The remaining 30% of the ruptures, they are usually the posterior septal ruptures. They usually happen following an acute occlusion of a dominant right coronary artery, and it usually occurs in the proximal half of the posterior septum. Coming to the types, there are two types, simple and complex. Simple is a direct straightforward communication between the two ventricles through a straight path, like a straight VSR, while in a complex, which includes the 47%, the course of the VSR that is separating the two ventricles is undulating as well and can be serpinguous in type. These are the types. The simple, which is showing that between the communication between the LV and the RV, secondary to the septal rupture, is a straight. In simple, as we can see in complex, it is a serpinguous type of VSR. Coming to classification, type 1 rupture is an abrupt slit-like tear and is associated within the first 24 hours of acute infarct. Type 2 rupture demonstrates an erosion of the infarcted myocardium and is usually subacute type of nature in clinical presentation. Type 3 rupture, it exhibits a concomitant aneurysm formation with subsequent thinning of the septum and then after a rupture, which is usually associated with older infarcts. Coming to the pathophysiology, when a VSR develops, it leads to LV volume overload. This leads to left to right shunt, which leads to increased pulmonary blood flow and pulmonary hypertension. Thereafter, the RV afterload is increased. This entire cycle subsequently leads to reduced cardiac output and ultimately leads to end organ failure. Predictors of developing ventricular septal rupture following a myocardial infarction are advanced age at the time of the diagnosis, anterior location of the infarcts, they are more common. Female patients are more predisposed. Patients with chronic kidney disease are more predisposed to develop VSR, and patients who are already on immunomodulators or steroid due to some immunological disease can have a higher tendency to develop VSR following infarction. Coming to the clinical history, the patient typically gives a history of acute myocardial infarction, which is either within the first 24 hours or within 5 days of the presentation, or the patient has a previous history of recurrent chest pain. Patient may present with acute dyspnea on onset with hypotension, giddiness, and in extreme cases, patient may present in the form of cardiogenic shock. On examination, we can hear a harsh pansystolic murmur with a precordial thrill, a loud second heart sound, and an audible third heart sound. Patients may have features of pulmonary edema, features of RV and LV failure, and as we said, it can present as a cardiogenic shock. Coming to the ECG, ECG usually shows the features of acute myocardial infarction or can show AV conduction block, predominantly in type of the posterior septal rupture. On X-ray, we can see cardiomegaly, increased pulmonary vascularity, features of acute pulmonary edema, or in patients with advanced presentation, we may see presence of pleural effusion. If we have a Swan-Ganz catheter in C2, then we can see a step up of oxygen saturation between RA and PA. And this is diagnostic of ventricular septal rupture. Echocardiography is a gold standard and it's the most commonly used technique to diagnose the VSR. On echo, we can see regional wall motion abnormality. The VSR usually is evident in the form of septal dropout. When a color Doppler is placed across the dropout, we can see a left to right shunt. We can see concomitant valvular abnormalities which is commonly in the form of an MR, which is usually present in the posterior basal VSR. And we can also determine the dimensions of cardiac chamber and its function. Here we can see the echocardiography, where on the 4-chamber view we can see there is septal dropout between the RV and the LV, and a color flow Doppler across the septal dropout shows shunting of the blood from left to right. Coronary angiogram are very important. 60% of these patients have a single vessel disease and are acute in onset. If need be, bypassing the obstruction increases the long-term survival. Coming to the natural history, if the patients are not treated, then within the first 1 year of presentation, almost 96 to 98% of the patients would have died if the patients are not managed in case of a VSR. Coming to the management can be in a form of medical management, surgical as well as percutaneous procedures. Here we can see a flow chart. So if my patient is presenting with acute myocardial infarction with a ventricular septal rupture and if he is hemodynamically unstable, then I would resuscitate the patient and take him for immediate surgery, or the better option would be to decrease the afterload in the form of an IBP or an ECMO and then take up for an elective surgery, delayed surgery. If anatomy is suitable and if the patient is unlikely to be a surgical candidate, then I would go for a percutaneous closure. If my patient is hemodynamically stable and he is having a large VSR, then I would go for a placement of an IBP or an ECMO, decrease the afterload, improve the state of the cardiogenic shock, improve the end organ function, and then to take up the patient after 7 days of the presentation. If the patient is hemodynamically stable and is a very small VSR, then we would delay the surgery as long as possible. If it is possible to close by percutaneous closure, it's a welcome option, or we continue the conservative management and take up as a delayed elective surgery. So by this approach, we can see that a multidisciplinary heart team approach is the core principle behind the management of VSR and good outcomes in these patients. Coming to the medical management, if the patient is having cardiogenic shock, definitely we need to resuscitate the patient. We need to put a Swan-Ganz catheter or a central venous pressure line, decrease the systemic vascular resistance in this patient in a form of an IBP and in form of inotropes, and if need be, patient can be placed on an ECMO in extreme forms of cardiogenic shock. So these are the multiple analysis of the multiple studies where we have seen the 30-day mortality outcome of the VSR with immediate surgical management at various time points and with immediate as well as the delayed intervention. So mortality is reduced, as we can see, as the time between the VSR and the surgical intervention increases, and this is likely because the myocardium that has been friable initially at the presentation of VSR becomes more stable, becomes fibrosed. However, in the GUSTO-1 trial, there was a 94% mortality at the 30 days without surgery, suggesting that the conservative management is not associated with good outcomes in these patients. So, a good approach would be to decrease the afterload, resuscitate the patient by putting an IVP, giving them a mechanical support, and take up the patient after 7 days of the presentation. Thus, this improves the survival as well as increases the success of the surgery, because the myocardium has become stable, the patient has become stable hemodynamically, as well as the end organ perfusion has been taken care of. Coming to the surgical treatment, the patient has to be put on cardiopulmonary bypass with adequate myocardial protection. We usually prefer the trans-infarct approach. Care should be taken that we suture only the patch, or we close the VSR with a patch by taking suture at the viable tissue. The closure should be without any tension. The suture lines have to be buttressed, and if the bypass is needed, it should be done before repairing the VSR. So the surgical approach depends on whether the location of the VSR is apical, is anterior or posterior. Coming to the first technique, where we have an anterior VSR, and this can be approached to an anterolateral incision directly on the infarct or the aneurysm. It is usually repaired with a gelatin or collagen impregnated polyester patch or with a pericardium. The patch should be sufficiently enlarged such that it is able to cover the VSR as well as it extends up to the healthy myocardium where we can suture it. The patch is sewn onto the LV side of the septum with pleated and mattress sutures, and thereafter the incision over the LV is closed by buttressing it with the PTFE felt on both the sides, and then this suture line is then again reinforced with a continuous suture line of toluene. So here we can see we have opened the LV across the area of the infarct or the area of the aneurysm. We directly enter into the LV cavity. We close the VSR with a patch. Here we can see the sutures are to be taken in the healthy, fibrosed or a good myocardium where it can hold the sutures. And then after, the LV incision is buttressed with a PTFE patch and is closed in the 2 layers. The other technique is the infarct exclusion technique, where a continuous suture is placed through a transition zone between the septum and the free wall of the LV, such that the patch is anchored in such a way that it separates the LV as well as the RV cavity. However, it does not leave any residual communication between them, and if need be, separated interrupted sutures can be taken. So here we can see the patch is continuously closed, the VSR is continuously closed with a patch, and then after, if need be, can be buttressed with interrupted sutures. So the final outcome would be like this, where the patch becomes a part of the LV wall and the infarcted and the septal rupture segment has been excluded without taking any sutures on them, and thus the LV and the RV has been separated and the shunt can be abolished, and then the incision is closed in 2 layers as we seen with PTFE felt. Coming to the third technique, the apical amputation technique. In here, if the VSR is immediately adjacent to the area of the apical infarct, then the apex of the heart is excised, and including the involved portion of the septum as well as the adjacent RV. Then using the strips of PTFE felt on each side of the septum and on the edges of the LV and the RV, heavy mattress sutures with polypropylene are taken, and these 4 layers of felt are approximated together along with the left ventricular myocardium as well as the septal myocardium. So this is the technique. If it is a distalmost apical VSR with an aneurysm, then we resect that part and we close it with a PTFE felt, which is on the external side, both on the LV and the RV as well as on both the sides of the septum, and then it is heavy mattress sutures are taken to approximate them. Similarly, in a posterior basal VSR, we approach to the inferior part of the LV, where the incision is placed on the infarcted area or the aneurysmal area, and then after a patch is closed, the VSR is closed with a patch where the sutures are taken along the healthy margin of the myocardium, and then after, if the site of the incision is if the area of the aneurysm or the infarct is large, then the patch augmentation of the free wall may also be needed to separate the LV and the RV. Similarly, in a posterior basal VSR, we can use an infarct exclusion technique where continuous sutures can be taken along the inferior VSR, along the inferior margin, and then after it can be buttressed with interrupted sutures, And then in this way we can separate the LV as well as the RV in such a way that there is no residual communication across the VSR, across the patch, and then the incision is buttressed with the 2 PTFE felts on either side. Coming to the post-op management and complications of VSR, IBP should be continued in the post-operative period in 1:1 mode. Any residual shunt, if present, should be detected as soon as possible in the ICU. If the pulmonary blood flow, the systemic blood flow ratio is more than 2, then the reoperation or reintervention is definitely indicated. Hospital mortality, despite of all the measures, nearly is around 30 to 40%. Cause of death in these patients is usually the refractory heart failure and cardiogenic shock post-operatively. Percutaneous VSR device closure. So a 15 mm defect size is optimal. Inferior or posterior defects are definitely challenging with the percutaneous VSR device closure. Serpingous defects are difficult to cross with a wire. Freshly infarcted myocardium can predispose to peri-device leakage or even device embolization. Attempting a device placement requires a thorough understanding of the defect size, shape and borders, and this requires characterization by both preoperatively TE and transthoracic echo. Coming to survival, patients who have higher operative mortality are patients who usually have RV dysfunction post-operatively, or they have presented preoperatively in the form of cardiogenic shock. Posterior or basal septal ruptures have poor outcome as compared to the anterior or the apical ruptures. Timing of the surgery very important. An elective delayed approach after resuscitating the patient improves the survival. Increased age at the time of presentation predicts the operative mortality. Coming to various studies, Hitmiller et al. Demonstrated 25% hospital mortality, of which 34% were posterior defects and 15% were anterior defects. Skillington et al. In his study demonstrated 21% mortality out of 101 patients, of which 33% were posterior defects and 12% were anterior defects. Thus, posterior defects have higher incidence of operative mortality. In this study, he also proved that the site of the infarct, the time interval between the infarct as well as the operation, and the cardiogenic and presentation of the patient with cardiogenic shock has higher prediction of early death following the surgery. In a study of 67 patients by David et al., operative mortality reported was 13.4%, where a long-term survival at 10 years was reported to around 62%. In the shock trials registry published in the year 2000, VSR was identified in 55 patients. Mean time of presentation was 16 hours post-infarct. 58% of them were female patients, and all of the patients were in cardiogenic shock. Overall mortality in these patients was 87%. 31 patients of these 55 underwent surgery, where 21 patients required concomitant CABG. However, still the operative mortality was 81%. Only 6 patients could survive. 24 patients did not undergo any surgery, which had mortality of 96%, and only 1 patient survived of these 24 patients. So, coming to my conclusions regarding ventricular septal rupture. So, any patient who presents with the VSR, it definitely is an indication of a surgical emergency, and a heart team approach is the most important approach, where the patient has to be reviewed both by the cardiologist and the surgeon. Patient has to be resuscitated, end organ perfusion has to be ensured, and then the plan for the surgery or any intervention should be planned. Factors that are responsible for favorable outcome include early referral of the patient to a specialty hospital, swift evaluation of the patient, swift planning of the management, early IBP support, and early surgery after 7 days of the presentation improves the outcome in these patients. Thank you.